Hello, my name is Grant Franklin. I'm one of the acute medicine and infection consultants in Raigmore Hospital in Inverness. We're going to be talking about Beyond the Pandemic, and that's the title. I'm joined today by Dr. Aqua, and perhaps you'd like to say hello.
Hi, my name's Becky. I'm one of the specialty doctors in Raigmore in infectious diseases and general medicine.
And I'm also joined by another colleague, Dr. Rowland.
Hi, I'm Kirsty. I'm one of the internal medicine trainees at Raigmore.
So our intention today is, rather than having a didactic lecture, we're going to have a bit of a discussion about how things have gone in the last few months and the future challenges. And it's really from the perspective of the COVID infection unit in Raigmore and those who've been involved in the care of patients and the collecting of data. So it's general lessons for NHS Highland from the perspective of the Raigmore COVID infection unit. And to start the ball rolling, I've got a few slides, or I should say Kirsty's got a few slides to talk about the statistics that we've collected. So over to you, Kirsty.
Thank you. So I'm just going to briefly talk about some of the data we've collected on the patients that have come through the red zone. We've collected this data with the help of Jonathan Byers and Andrew Martin as well. So we're going to look at the patients that were admitted between the 23rd of December and the 28th of February. We're not going to include the 2 patients who were admitted directly to intensive care. So we had in total 134 patients who were admitted in that timescale. One of the patients is still an inpatient, so we've excluded them from the analysis. And the split was 55% were male, 45% were female, and the age range was from 21 being the youngest patient to 94 being our oldest patient, with the median age about 62. This is just a brief slide on the baseline function of the patients who came through the unit. So 86% of patients were living independently at home prior to admission. 7% came from residential care, and another 6% came from home with the assistance of carers, and there was 2 patients from sheltered accommodation. Looking at the comorbidities of the patients that came in, 21% of patients were diabetic, 21% had pre-existing lung disease, and 6% were immunosuppressed. There's a variety of reasons for this. Probably it may seem like small proportions, but it's likely that a lot more patients would have been shielding, and that might have swayed the number slightly. Looking at obesity and smoking, unfortunately, obesity wasn't thoroughly documented in all patients, but we know that 41% of patients were documented as being obese, so BMI over 30, that were admitted. There was another proportion of patients where it was not documented, so it's unclear if actually more patients than that were obese. And in terms of smoking status, again, unfortunately, this wasn't always documented, which would be something that we could improve in future. But surprisingly, only 6% of the patients that came in were current smokers. But a large proportion were ex-smokers, and like I say, the smoking status of quite a few patients wasn't documented, unfortunately. This is an attempt to show the spread of patients that we admitted. So we know that NHS Highland covers a huge area, but you can see from here that we have had patients from as far north as Wick and Thurso, from the Western Isles, quite a cluster of patients from Barra, and then down south towards Fort William and Aviemore area. We also had 1 patient from Indonesia and another patient from the Glasgow area. And this is just a kind of zoomed in a map showing the postcodes which were most heavily affected. So the majority of the patients were from the sort of IV2, IV3 Inverness area postcode, along with a cluster IV8, Black Isle area, and sort of IV15, 16, 17, so Dingwall, Alness, Invergordon area. Again, that's probably contributed to in an area like the Highlands by population density. So these are the areas where the populations are highest, but that tended to be where we were seeing most patients coming from.
But I just interject there, Kirsty. It is interesting that we had, on this map at least, no patients from the West Coast at all, and that seems really very surprising. We certainly had more in the preceding waves, but in this most recent wave, it seems that it's been where the population has been dense that we've had the cases. So I think that's quite interesting, a difference from last spring. But I'll let you carry on.
So this is just a slide looking at the level of respiratory support that the patients that came through the red zone required. So about 25% of patients actually didn't require any supplementary oxygen at all. Dr. Franklin was pointing out earlier that this may be because some patients were coming through the unit who had been admitted for other reasons, and perhaps they had other health problems and they happened to have COVID. So perhaps we're not unwell from a COVID point of view, but there were a reasonable amount of patients who didn't require any supplementary oxygen. About 41% of patients required oxygen, just simple oxygen without any ventilatory support. Some required high flow nasal oxygen, and there were only 9% required ventilation and intubation and ventilation in intensive care.
And again, this is interesting, a big difference from last spring, where we used essentially no high flow nasal oxygen because there was a great concern that it was in itself an infection control risk because of the high flows of gas involved, and we completely avoided using it and used CPAP as our main mode of oxygen delivery when we were requiring high FiO2s. But in this most recent wave, we had much better science backing up the use and safety of high flow nasal oxygen, and a strong suggestion that CPAP might actually be counterproductive for people with the very stiff COVID lungs that we have seen. So we found high flow nasal cannulae very, very useful in this most recent wave. And again, back to you, Kirsty.
So this is a slide showing the antibiotic usage in the patients. As we know that antibiotics are not useful for COVID unless there is evidence of superimposed bacterial infection. And I think we did quite well from that point with most patients not receiving any antibiotics.
And I think it's worth commenting that yes, antibiotics aren't useful for COVID, but I think this is one of the advantages we saw with a very small, tight team, particularly the senior team. We were infection trained consultants and registrars who were used to avoiding the use of antibiotics where they're clearly not relevant, and I think that in preceding waves, we actually saw higher anecdotal use of antibiotics because there was a much wider group of clinicians involved. So this, I think, was a step forward. Thank you.
Definitely. So this is looking at the outcomes and the length of stay. So the minimum length of stay was 1 day and the maximum was up to 72. The median length of stay for the majority of patients was about 5 days. Of the patients that came through the red zone, 25 were subsequently admitted to intensive care. And of those 25 patients, 4 patients sadly died. The other 16 patients who died passed away either on the ward or in high dependency in the red zone. But overall, that means that 15% of the patients that came through the red zone unfortunately died. And this, I think, is quite a stark representation of how your baseline level of function affects your likely outcome. So you can see a very high proportion of the patients who were independent prior to admission were discharged with a fairly low mortality rate, as opposed to when you get to the patients who have come from residential care, almost 3/4 of them sadly died. And the patients who have had a sort of medium level of function and were living at home with carers, nearly half of them passed away.
Yeah, I think that's fairly shocking statistics, but in this situation, it's not surprising. It's very much in keeping with what has been reported elsewhere. But I do think that's quite a stark reminder of what we were facing. Thank you. I think it's the next slides are for Becky. So Becky, I'll pass over to you for the next few slides.
Thank you, and thanks, Kirsty, for giving us an overview of the data of our patients over the last few months. What I'm going to try to do is give you a picture of how the ward, the staffing levels, and our clinical practice changed very quickly over these 2 months and how we dealt with that, including some of our achievements and our challenges. And we'll touch on some of the challenges that we had and have going forward with infection control. So at the beginning of January, after the Christmas period, we'd had a few patients in over the Christmas period, but we all came back from our leave knowing or expecting quite a big wave based on the community prevalence rising. So we started with 3 patients, but we were very aware that we had to prepare for a significant rise in this. And by mid-January, we had 34 patients and a very full functioning ward. So to cope with this, we had to prepare and change daily the number of staff that we had on the ward, both medical and nursing staff. The COVID infection unit is based in a ward called GA, which was previously used as an acute medical admissions unit. We started with 1 bay and 3 side rooms, and the medical team included Dr. Franklin, Dr. Beadles, and myself. And as the days and weeks went on, we had to increase that to include further junior doctors, advanced nurse practitioners on the medical side, and the nursing staff were pulled from the ward GA, from high dependency unit, and also then from other wards. And as you can imagine, that was quite daunting for some of these nurses to do that. As well as that, we had to make sure we had cover overnight. As the number of patients rose, we didn't want to have cross cover from other parts of the hospital, especially with patients that were potentially deteriorating very quickly. I think through this, it was very clear that we had an excellent team spirit and our teamwork was excellent. We had new staff members joining all the time, and everyone was very willing to adapt and to work hard to get the work done. I think it's very interesting that we were all very adaptive in our roles. So in order to try and spend as little time in the red zone as possible with the patients, we were able to take on roles from other members of the team. So we would assist the nurses in their jobs and vice versa. As the days went on, obviously our clinical practice had to change very quickly as we got information from research and evidence that was being published. So we had to have a very fast-paced environment, and we had to learn how to use new drugs daily, as well as being updated on the research that was undergoing on our unit. The communication is very important. Our patients were at risk of deterioration, and it was very important that everyone was aware of how quickly patients could deteriorate, who was at risk of deterioration, and who was for further escalation. In addition, we were admitting patients directly to the unit, and these patients had to be assessed very quickly and seen by senior members of the medical team. We had a board round several times a day where we discussed these pertinent points, and so everyone in the team, the nursing team, the medical team, and the multidisciplinary team, including physiotherapy and occupational therapy and infection control were all aware of the patients and their current situation. It was also important that we could update families, as there was no visitors allowed except for exceptional circumstances and palliation. And therefore we, as a team, we updated every family every day. And this was, I think, very useful for very anxious families sitting at home. So when we were preparing this presentation, the word that really came to my mind was collaboration. We had to work quickly and collaborate with different people as the weeks went on. We had research teams based in the wards, and the clinicians on the ward were also trained into enrolling patients into the recovery trial. We discharged patients into the care of the COVID follow-up team. So we had to work closely with them to make sure there was a good linkage between the ward and themselves, and also vice versa. We accepted patients back from them when they deteriorated at home. Of course, we had to collaborate with intensive care, and they frequently had reviewed our patients prior to them deteriorating and requiring ventilation. The respiratory team were present on the ward and providing clinical input. And of course, as we were accepting patients from all over the Highlands and the Western Isles, we had to collaborate carefully to ensure safe transfers of patients to us for care and to get them home safely again. And of course, we had infection control, and this was really important in terms of stepping patients down from the ward, as well as our practice within the ward to keep the staff and other patients safe. So I think the treatment discussion is beyond the scope of this talk, but just to point out that we really had to learn on the go as to which treatments we could use. As part of research trials, we were using aspirin, colchicine, prazocative, and tocilizumab. Tocilizumab later became standard practice for some patients, along with dexamethasone. As Kirsty pointed out, we had a very low antibiotic use, and the other treatment we used was self-proning, and we saw a huge benefit to patients on proning, and all the staff were trained in how to do this. So as you can imagine, the ward had to change very quickly. So we started off with 1 bay and 3 side rooms, and within a week or two, we had increased to 5 bays and 6 side rooms. We were able to have a completely red ward, which made infection control easier. In intensive care, they had to create a red ITU and a separate green ITU. So they had 2 functioning intensive care units. Yeah, next slide. So some of the infection control challenges that we faced, the main one was trying to step patients down from the ward. So obviously with some of the uncertainty with COVID, and we're still learning as we go along, it was not always clear if someone was safe to be stepped down from the ward. But even when we were quite confident that it was safe and they were no longer infectious, there seemed to be quite a lot of anxiety from other parts of the hospital and other staff in the hospital. And we really struggled with some patients trying to discharge them from the ward, which was important for their own care, as they may have received more rehab in other parts of the hospital, but also for us so we could accept more COVID positive patients. At the beginning of the wave, we struggled trying to get investigations, for example, CT scans, as they were always being postponed to the very end of the day, often when there was less medical staff around and these patients needed escorting to CT scans. That was something that we were able to fix quite quickly, with collaborating with the radiologists. There were some members of the MDT who had to work in green and red areas, and they often felt that they could only come to the red zone at the end of the day, and whether this had some impact on patient care is possible. And for 34 patients, there was a huge staff number, and we had really quite a small staff room, and had to make sure that we were not breaking social distancing rules in that staff room. So it's another challenge that we had. So currently, thankfully, we're only having sporadic cases only, but we are working in a hospital with no specialist infectious diseases ward. So currently, we require a whole ward to be blocked off to await a patient possibly coming with COVID, and that means that we have beds being unused in Raigmore currently. And if we have to open up that ward, we need more staff in the case of even just one COVID positive case. So very briefly, I'll just touch on some of the staff experience. So they were asked to comment on how they found the experience of working in the COVID infection unit. And really, it was quite an inspiring time. I found it really rewarding to work with the team. I think everyone worked really hard. We worked together, and really, it was overall a very positive experience. There's some of the things that our staff said. That was team spirit, that we were working together, that it was amazing. There was research, there was encouragement, and there was laughter. And I think the negative experiences, we were dealing with patients who were very sick, who could deteriorate very quickly. And for a medical ward, the high mortality rate is something that we are not used to. We were looking after and palliating patients sometimes without their family members being present, and having family members present over FaceTime. That was really quite hard to deal with, and I think the staff found that very difficult. It was also very hard work, and there was a lot of pressure for staff to learn quickly and adapt quickly. And you can see there that some of the staff felt scared, they felt lost, and they felt heartbreak.
Okay, I think that's your last slide, Becky, but I don't want to end on a negative. I would like to comment on what you said about the amazing team spirit. And yes, we did have to deal with all of what's on this slide, but in some ways I think the slide before is more important. The positives that came out of the sort of team spirit and the sort of way that the staff collaborated was absolutely fantastic. Of course, there were tragedies to be dealt with, and heartbreaks that are affecting families still. But I think overall, the staff involved made an amazing team, and that to me was a massive positive. So, just the last couple of slides are down to me. The next challenges. Well, we need to be able to continue to provide COVID readiness, even when we're seeing very, very few patients coming through the door. And that's a challenge in that we have an empty area for most of the time, but we need to be able to staff that area at a moment's notice, and that's very, very difficult, very disruptive to other workflows within the hospital. We do, within the rest of the hospital, still have to continue all the COVID secure admission policies, and infection control guidance is very much at the forefront of people's minds. And it is a challenge to keep that going day after day after day, particularly when we're seeing local infection rates being very, very low. But we do need to remember what's happening elsewhere in the world, and realise just how lucky we've been, even in the midst of our most recent wave, when things seemed pretty horrible in NHS Highland. We, in relative terms, were doing much better than most of the rest of the UK, and indeed most of the rest of the world. So I think we've been very, very fortunate, but it does continue to be a challenge going forward. And I think that's a challenge particularly when we don't have an area that's designated and designed for infections of high consequence. So for those of you who are watching, if you have any clout in the organisation, or indeed in the Scottish Government or wherever, NHS Highland needs an infection unit. We seem to be well on the way to planning it and getting it organised, but I'm very keen that we get it across the line as quickly as possible, because I think we're facing an ongoing tale of this pandemic, and indeed possibly a further wave of infections. But we're also immediately needing to face up to the challenges in the future. And that's not just the challenges of the next pandemic, but the challenges of other emerging infections and hospital-acquired infections that we need to be able to deal with in a 21st century manner in the Highlands of Scotland. We need an area that's designated for that, with negative pressure rooms with space for donning and doffing, and we need the ability to expand that area when we're faced by the sorts of challenges we faced in January and February. I think we probably are at the end of our time, and I think we should call it to an end. And just to say thank you very much. Normally, obviously, there'd be time for questions, and we'd happily take questions. If you wish to contact any of us, we're easy to find on email, and we'd be very happy to make contact and discuss anything that this presentation has brought up in your minds. So thank you from me, and I'll let Becky and Kirsty say thank you in turn.
Thank you, and I hope you enjoy the rest of the conference.
Thank you.
That's great. And I think we'll call it a day.